right, let's come to the big story this evening, and everyone's talking about vaccines. Every time we hear the news that a vaccine or a drug maker essentially has made a big breakthrough in the hunt for a COVID-19 vaccine, it fills everyone with hope and joy. But this one is special because the Oxford AstraZeneca vaccine is being made in large quantities already in India by the Serum Institute of India. They already have about 40 million doses here, and by the end of the year there will be 100 million doses. So selfishly and largely from the Indian context, it is the biggest of the announcements because it's most likely that that's the one we will get here. So what is the news? So the news is that there are various ways of dosing it. One of those combinations gives you a 62% efficacy, the other one gives a 90% efficacy, so on an average it's a 70% efficacy. How does that compare with Moderna and Pfizer and all the other vaccines that are in line? By when can we get it, and will it really be the game changer? To speak on some of these issues, I'm joined now by Dr. Ramanan Laxminarayan, Director of CDDEP, and Anant Bhan, who's a global health and policy expert. Welcome to the both of you, and thank you for speaking with us again. Dr. Ramanan, let me begin with your take on the Oxford AstraZeneca news and put it into context for us on how far we are from the finishing line with this announcement.
So this is extremely good news, obviously, because this is the vaccine that is most relevant to India. The mRNA vaccines, which Pfizer and Moderna are working on, are difficult vaccines for the Indian context, both because they require storage at very high temperatures. They also are much more expensive. This particular vaccine, which Serum is also invested in producing and scaling up, is likely to be far more affordable. The price will likely come down even further with volumes. And most importantly, the vaccine can be stored just in a regular refrigerator rather than being stored in deep freezers at minus 20 or minus 70 degrees. Also, the mode of delivery of these vaccines is much simpler for the Indian context compared to mRNA vaccines that require more complex injections that have to be delivered by trained medical personnel. So from all sides, this is really good news. The only things that remain to be known in a sense are that as we roll the vaccine out, we'll have a better understanding of efficacy and of safety. And this is what is called phase 4 in a sense. And the other part is, of course, that we still don't know for any of the vaccines the duration of protection. We don't know if it will last 3 months, 6 months, a year, or for a lifetime. Obviously, the hope will be that the duration of protection is a lifetime, so we don't have to get vaccinated again, like you get vaccinated against measles or mumps when we're children, and then we don't have to get vaccinated again. That's the hope for this vaccine. But those are some of the unknowns that remain.
Anant Bhan, if you can explain to us how it compares, because it's a different platform as compared to Moderna and Pfizer, which are on the messenger RNA. So is this more effective, less effective? How would you compare it with what we have seen in terms of announcements of vaccines so far?
Sure. Thank you for having me, Tamanna. So I think it's certainly very encouraging news, as Professor Ramanan was saying, but we have to also make sure that we understand that these are interim results, and we need to be watchful of future continuing trial results. That having been said, as was highlighted, the advantage which the Oxford AstraZeneca trial vaccine has is that it's also, first of all, an easier vaccine to work with. It's also being trialed in a much larger population than both the Pfizer and Moderna vaccines are currently. And it's also being planned, it's also being trialed in India. So from all of those perspectives, it's likely we will have a combination of local efficacy data and an easier integration into the national immunization program. It's a vaccine platform which would be relatively easier and something which our health system can deliver at scale much more faster than an mRNA-based platform, which obviously has complexities because of one, it being a very new platform and not enough being known about it, plus the requirements for a lot of ultra cold storage, which is going to make it challenging. In terms of numbers, I think we can say that you can compare whatever 90%, 70% to a 94.5% and a 95%. I don't think it's probably, the right way to compare the metrics right now, because these are interim results. We will have to probably look at long-term results. But you have to also remember that these vaccines have only been development for 10 months or even lesser. And hence, there's a lot we still need to understand and know about safety and efficacy. But overall, these are really encouraging results, all three vaccines, and I think that should give us a lot of hope moving forward. But we should also remember that we need to be cognizant about the longer-term data being equally important.
Yeah, it's one of those rare times when the layman and everybody really is now tracking what the efficacy of a vaccine is, which most people outside of course, medical circles didn't even know what that means. So, Professor Ramanan, that's actually an interesting point. What does it mean if one vaccine is on an average 70% in efficacy and another is 94 point something and another is 93 point something? Does it mean that one is better than the other or is more likely to work?
So let me explain the numbers, how they work. So the way these clinical trials are done is that, say, 100 people are given the vaccine, 100 people are not given the vaccine. Then we look at the numbers of cases of infection that happen in the folks who got the vaccine and the folks who did not get the vaccine. And in the absence of the vaccine, let's say you would have had 10 cases, but with the vaccine, you only have one case, then that's a 90% efficacious vaccine because, essentially the vaccine was able to prevent 9 cases, which is what you see in the unvaccinated, bunch. So a 90% vaccine is pretty good. So 70% vaccine is also, it's pretty good in the sense that, keep in mind, this particular vaccine from Oxford, the major concern for this was that it is, the way it's built is that you take another virus called an adenovirus, and you basically are putting in the particular information, the genetic information of just the coronavirus into it, and then you're putting it into the body. There's scope for, side effects. There's scope for the body recognizing that adenovirus and saying, oh, I already know how to deal with you, and then neutralizing the adenovirus. So it's entirely possible that this vaccine might not have worked. But it's, it's actually, I'm strongly encouraged at the fact that this vaccine works at all, because it gives us hope that we might even be able to tweak things on the dosage. So as you said at the beginning, the half dose followed by a full dose a month later, happen to be far more effective than, 90% efficacious compared to the one which is 2 full doses apart. We still don't understand exactly why that was the case. And so I think there's room to improve here as well. But overall, for a first pass, this is very encouraging. But as Dr. Bhan said, it is still early days because we're only getting data from a very small number, and we will have to wait for the full trial data and also the published results, because we had some information a couple of days ago saying that there was good protection in the elderly population, which is data which have not been reported from the other mRNA vaccines. If that is true, that's extremely good, because we could give it to the elderly, and that would save a lot of suffering and hospitalizations and mortality. So let's be optimistic, but cautiously optimistic.
That's another question I had in mind, Anant, is these are right now all claims from companies. They still have to be independently verified by the right authority in various governments, isn't it? Or the WHO, or whose stamp of approval finally will tell us that these are good to go?
Well, typically, it's a few steps involved. One is certainly the regulator. So, for example, in our country, it would be the CDSCO, the Central Drug Standard Control Organization, the DCGI's office, which will look at the data which the sponsor, the company, will provide them, and then evaluate if that data is satisfactory through its expert groups. It will also be the case that if this were to be integrated into the National Immunization Program in due course based on more data, then entities such as the National Technical Advisory Group on Immunization, NTAGI, which functions within the Ministry of Health and Family Welfare, will look at it. Likely, WHO obviously has groups, expert groups, which look at this kind of data as part of their pre-qualification process, and that is required for companies to be able to widely distribute it from a global health perspective. So there will be a lot of people looking for that data, including actually all of us. We'll all be very curious to actually discernibly be able to examine the data and see whatever claims are being made by the sponsor are actually verifiable in the way the data is presented in peer-reviewed publications, but certainly the regulator at a first pass. The second thing I just want to quickly add on is that efficacy within a controlled clinical trial has to be again contextualized in the with respect to the fact that when you actually deliver these vaccines at scale, the net effectiveness of that vaccine will also be defined by the coverage of that vaccine. And we know that even with our existing national immunization program, we don't have 100% coverage as it is for some of the vaccines we've had for decades. So actually the net effect we will see at the population level will be a mix of the efficacy of the vaccine as well as how well we are able to get coverage done. And that depends on how well we design our immunization program for COVID-19 and how effectively we get the vaccine to the doorstep or to all of our rural communities, remote communities. And that is another challenge that we need to keep talking about and thinking about.
Absolutely. I'm going to change track just a bit because, till the vaccine comes, our biggest challenge right now is to ensure that we don't go into a situation where cases are out of hand. And that is one concern that I want to address with both of you as well. In light of what we've been seeing over the last few days, night curfews are back in some states, in certain districts. The state of Maharashtra today has ensured and has said that people coming in from 4 places, Goa, Rajasthan, Gujarat and Delhi NCR by flight, rail and road will have to be screened and will have to have negative COVID tests before they can enter. So my first question to Anant Bhan on this, is it looking like, are the numbers looking like they're going back to a worrying space? Because if you look at them in isolation, it's not as alarming as it was, say, a few months ago. The numbers in various cities and in these areas. So what do you think is leading policymakers to sort of take all of these precautions? Are we looking like we're headed in dangerous territory?
Well, we can only surmise from what official data we get, but we also note from what the government itself has said that the actual number of cases based on tests which are confirmed positive is only giving us part of the picture, because the number of people who were potentially actually infected in the past and perhaps are continuing to get infected is much larger. That's what our seroprevalence studies anyways tell us, that the number of people who probably had infection is much, much larger than the official numbers based on the tests performed. The second element is what tests are we performing and what mix is there of gold standard versus rapid antigen tests, given that there is relatively less reliability with antigen tests. It's certainly the case that many of us have expressed concerns in the past that with the festive season coming in, there was always going to be a higher risk attached with higher social interactions. And unfortunately, that is certainly seemingly manifesting with a higher number of positive tests coming through. And perhaps that is what is spooking many governments, along with the combination of impending winter, ongoing cold temperatures, as well as pollution in some parts of India, which might mean more respiratory ailments, etc. And unfortunately, at least in some parts of India, it seems that the health systems are starting to get stressed. We all have heard those stories from Delhi and other parts of India already. So again, I think this is, this has been now happening for many months. We've had situations like this before. Hopefully, governments have learned from that experience, and they will come up with evidence-based responses. What I'm very surprised at seeing are responses like night curfews, which what purpose do they serve besides just the optics of saying that we are doing something? If you really want to address it, you have to do it more comprehensively and driven by data. But beyond that, it doesn't really make a lot of sense. So, hopefully, again, like we've seen before, it will not be just a law and order response, which is what usually they do, but a public health intelligence-driven response, which is what we should be seeing.
Yeah, but that's par for the course. Dr. Ramanan, what I'm trying to understand is what has changed now in the last couple of weeks, which is driving various local governments to go in for things like night curfews. How do you look at the Maharashtra government's measure from today, beginning to restrict entry? And for most people, the fear is that this points to a situation which could get worse with more restrictions in place.
Well, test positivity rates are going up. Delhi now accounts for a quarter of deaths across India, highest rates, so far. Gujarat is facing high death rates and increasing case rates. You're seeing this across North India, at least in the places that are testing. And what Maharashtra is doing is the logical response, which is they have tried very hard to keep things under control, and they don't want an influx of new cases coming in from these high-risk states. So they're demanding that people who come in from those states actually have a negative RT-PCR test, which I think, makes a lot of sense. And this kind of proactive work, 7 months ago could have put us in a very, very different situation compared to where we are right now. So, but as Dr. Bhan just said, the causal factors are the same across North India, which is the cold, the pollution, and the festival season. And the cold is not just to do with the respiratory virus. Cold generally drives people indoors, and we know that much transmission happens indoors when people are not wearing masks. And of course, people are not wearing masks inside the house. In Delhi, there's a 2,000 rupee fine if you don't wear a mask outside the house. But outside the whole house is not where most of the transmission is happening. Most of the transmission is happening inside the household. And obviously, you can't demand or enforce mask wearing there, which means that the main solution we have, as was from the beginning of the epidemic, was to have tested widely, tested often, and the rapid antigen test, again, we made the mistake of replacing RT-PCR with a rapid antigen test, when what we really should have done is focused on getting the rapid antigen test as a way of detecting infections quickly to isolate people, but giving everyone who was negative for a rapid antigen test the RT-PCR test. That, to my knowledge, has not been done across most of the country. So there's a lot of people who get a negative rapid antigen test and assume that they are fine, and they go on spreading to other people. So I think, again, this law and order response, again, as Anant said, this is not the solution, and this is not going to be the solution going forward. We might find our way out of this entire pandemic because of the vaccine, but I think we have not really put in place a science-based strategy across many parts of the country. Some places have, and there are very good examples across some places in the country which have had a science-based response. But in general, that has not been the case.
No, so what do you make of the night curfews? Like Anant also said, that how are the night curfews going to help? And then what are the next steps from here if cases keep rising? Because policymakers and local administrators want to show some kind of action.
That's all it is. It just is it's demonstrating action, but it has no real effectiveness from a disease transmission perspective.
Yeah. All right. Thank you so much to both of you for joining us and talking us through some very confusing, troubling times, and confusing because some days the news is good, like with the Oxford vaccine, and then some days it's troubling when you learn that a state is beginning to screen people who come in once again, just as we hope we're nearing the end of this. So thank you to both of you for joining us today.